Okay, so good afternoon, everyone. Thank you for being here this afternoon. We have with us today Dr. Susan Rogers. She is the immediate past president of PNHP and is recently retired from Stroger Hospital at Cook County, where she now serves as a volunteer attending hospitalist and internist. While at Stroger Hospital, she was co-director of medical student programs for the Department of Medicine and received numerous teaching awards. She's an assistant professor of medicine at Rush University, where she serves on the Committee of Admissions. Dr. Rogers received her medical degree from the University of Illinois College of Medicine and completed her residency at Cook County Hospital. She previously was medical director of the Near North Health Service Corp, FQHC in Chicago. A longtime advocate of healthcare justice and racial equity, Dr. Rogers has testified before Congress and spoken to both medical and community audiences around the country. She is joining us today virtually to share her insights on a crucial topic, which is disparities in healthcare. Dr. Rogers, I just want to say that we are very honored to have you and look forward to hearing from you. Everyone, please join me in giving a warm welcome to the exceptional Dr. Susan Rogers.
Well, thank you for that nice introduction. Can everybody hear me okay? Okay. I want to talk a little bit about race or racism. Which one is it really in our healthcare system, which we know is riddled with health inequities, many by, income, by race, by other factors too. But why is it that we have all these inequities? And one of the reasons I'm involved with Physicians for a National Health Program is hoping that a single payer mechanism, funding of healthcare would help address that. But even though it will help address it, it will not solve the entire problem. And I hope that I can show you why I feel like that. And one of the things we have to realize is that many of the inequities that we see, even when we control for social economic status, not being poor does not necessarily prevent you from being a victim of racial inequities and it doesn't protect you from bias within the healthcare system. Look at what happened to Serena Williams. She almost died from a post-delivery PE. And this is a woman who could have bought the hospital. Her socioeconomic status had nothing to do with it. She's an athlete. So you would think that if a professional athlete is telling you they're short of breath, it should mean something. But all of her symptoms were denied, and she had to really push and force them to do what was needed. So not being wealthy, being of good economic status does not prevent you in this country from being a victim of health inequities due to race. Let me see here. Okay. So one of the things in medicine, is that we live on definitions, and it's what we say means it really is important of the words we choose to talk about what we're talking about. And if you look back at before you were in medicine, you all knew what a rash was, or so you thought. So if you call a dermatologist to see a patient because of a rash, they have no idea what you need. So we have definitions, and so we have to be careful about the words that we use so that we are saying the right things. So systems and institutions often use, let me try to, okay, there it is. Systems and institutions, they produce often disparate outcomes, regardless of the intentions of the people who work within them. So there is a structure within healthcare. There's a structure within almost every system in this country that is built on racial inequities, racism, and all to get the result that they want. So regardless of your personal intentions, it's the system that often gets the result that it was designed to get. And what we see is often the tip of the iceberg. And the tip of the iceberg is often the most blatant racist activity that we see, but it's really the base of the iceberg, which we never see. We know that icebergs can be, 10 times larger, 100 times larger beneath what we see. And that's where all the rules, the policies and all, that's the structure that allows the iceberg to survive. And that is also the structure that allows racially disparate outcomes to survive. So again, getting back to definitions, what are health disparities? And if we look at health disparities, disparities just refer to differences. It doesn't give you any indication as to why or who caused it or what did it. It just means a difference. And it's like, why do basketball players have more knee injuries, for example? It's not because their knees are different. It just happens because of what they're doing. And so if we look at health disparities, they don't really tell us anything necessarily about why, other than you can group populations and see, but it's not really, it's just a difference in outcomes. It doesn't tell you why. However, if we look at what are health inequities, that implies something moral in it. It implies that something is unequal. There's something that shouldn't be there, and it refers to differences that aren't that are unnecessary, they're avoidable, they're unfair, and they're unjust. And the WHO, the World Health Organization, uses the term health inequities. The United States, unfortunately, continues to use the term health disparities as if we don't want to acknowledge the fact that these inequalities shouldn't be there. But I encourage you to always use the term health inequities because it is unfair and unjust. So, our biological differences among the causes, and that's where we get into race or racism. What is causing these inequities? And there's been a lot of data that has been produced over the years from, during slavery times, and a lot of the data produced in slavery has been taken as fact and never really addressed as, is this really real data? They did studies on craniotomy sizes, and this was done to prove that Black slaves were cognitively inferior to white people who lived here because their brains were smaller. And what they did was they filled skulls of people who had died with seeds. And so they said that the white skulls held more seeds than the Black skulls. And this has been proven since that this was not true. However, we still use that myth to justify that Black people are inferior. And that's what race norming in the NFL did exactly. You've heard about the chronic traumatic encephalopathy that football players get from repeated hair traumas. And when it came time to compensate these players for their loss of cognitive ability, it was adjusted for Black players, assuming that they started at a lower level of cognitive function compared to the white players. And we're talking about a tremendous amount of money because these aren't older people who have dementia. These are young men who often their bodies are fine. It's the brain. So they have many years to live. And it's important that they get compensated accurately. But they did race norming. And this has been held in neurological studies. They've been doing this for years. This isn't new. But this was done with the approval of physicians. So here we are, hundreds of years later, when this was supposedly proven that the craniotomy sizes of Black men were smaller, we're still using that data to decide how to compensate Black players here in 2024. I think these things started happening in 2022 when they started to compensate these players. So this is still persisting despite knowing better. We continue to do that. The vital capacity and spirometry studies that were done in the 1800s and 1900s that were done to try to figure out how bad TB was affecting people, since a lot of the country, especially in urban areas, were affected by tuberculosis. And this was done to help decide how bad the tuberculosis was in certain individuals. And so what they did was they did these studies, and they showed that the lungs of white people were better functioning than those of slaves. And so that justified the use of slaves doing hard labor, because this would help build up their lungs. So all of these myths, all of these studies, which have really are not scientifically based, but they justified the use of slaves, of Black people as slaves, because it was better for them, or that was all that they could do. And this is carried down. If you look at your pulmonary function test results, it has two ways to calculate the results, because there's an adjustment factor for Black patients versus, and there isn't one for white patients. This has continued. And a lot of that is that it's just sort of, nobody thought about it, or nobody cared about it. But it really affects when people are allowed, when they qualify for, let's say, lung resection for lung cancer, depending upon how bad their lungs are. It decides who is eligible to get oxygen. All of these things are based on these studies, and who loses? Black people, minorities, people of color, because of these studies that really are not based in facts. So we can go down this list. I won't get into all of them, but they all use race as a factor in deciding who gets what and who doesn't. One of the things I want to point out is this diagnosis. I don't know if you've heard about it, excited delirium. And this came up, I'm not sure who really came up with this term, but it is used to describe the aggressive behavior that Black men may have when they're stopped by the police, especially if they may be innocent. They're stopped for no reason, or they're treated inappropriately after being stopped for a minor traffic violation. And so they've come up with the help of physicians, mind you, of this diagnosis of excited delirium. And this has allowed the police to be indiscriminate in the use of ketamine when they stop Black men for violations or for whatever reason. And many have died because of the inappropriate use. And there have been many psychiatrists who work with the police to justify this. Now, the Association of Psychiatrists does not agree with this diagnosis. There is no such thing. If you look into their websites, there is no diagnosis excited delirium. However, the police continue to use that. So that there's a lot of, quote, science-based behavior that is justified by the use of, quote, science that has never been proven. And it inadvertently, deliriously, negatively impacts on Black people in this country. Also, migrants, people of color, anyone who isn't white often can be a victim of some of these inequities that are supposedly proven by science, but they aren't. And GFR is another big one that most, I think, at least larger teaching institutions have eliminated this. But before the GFR, which is what determines when you're ready for a transplant, when you're ready for dialysis, how bad your kidneys are. But it was there were two different results, because, quote, Black people were more muscular, and knowing that your creatinine is based on your muscle mass, their creatinine was normally higher. And so even now, Black people are not put on the transplant list soon enough. They're not placed on dialysis soon enough, because it is felt that their kidney function is better than what it is. And this is all based on these biologic differences of race, which has never been proven. And we continue to use these. And as physicians, we can't use unproven biological differences to explain the differences that we see. And what this does is it actually hides the effects of poverty and racism within healthcare. Now, this is a picture I wanted to share with you. This is my husband and I, we were in Africa, South Africa, maybe about 7, 8 years ago. And we were in Cape Town, and we came across this thing on this plaque that was outside one of the judicial courts. What this was is noting what was done before apartheid ended about how people came to the court to change their race. Because at the time there were 7 races, and according to your race, it determined what rights you had as a citizen. If you were determined to be white, you had all the rights. If you were determined that you were Bantu, which had the fewest rights, and some people came to argue against that. But the whole idea that the judicial system was deciding your race and deciding where you could live, where you could work, what you could do, what rights you had. And then we as physicians use this as a scientific factor. There's something wrong here. So how do we put race into these algorithms now as just as much as we use diabetes or your creatinine? That's based on science. We have a definition for diabetes. We have a definition for what certain things are in medicine. There is no definition that is based on science for race, and I'll get to that in a second. But this is what has happened, and it has continued over the years. And what has happened is that it is really a totally subjective, and it is guided by what the society decides it wants. And it allows them to get the decision or to get the result that they want to see. So what we have found, though, with the Genome Project is that there is no scientific definition of race. W.B. Du Bois did a study in Philadelphia at the late 1800s. And what he found, what he was looking for was, why is it that the Black community had such significant worse morbidity and mortality from tuberculosis than white communities? And what he found was that it wasn't race, it's what we now call the social determinants of health. Black people lived in crowded communities with poor sanitation, poor access to food, jobs that created high contact with people who had, just like COVID, but what they did was that they said that this was because of race. And Du Bois at that time said, no, it wasn't because of race. It was because of all of this. And then that was again proven in 2000 when the Genome Project was finally finished. And Venter, who was the lead scientist on that in that study, determined that there was no concept of race with any genetic or scientific basis. It is a social construct. It is not a scientific fact. And so the sequencing of this project was crucial. However, it doesn't seem to have really been accepted because we still use race to justify some of the decisions we make, or whether you should get this drug or that drug or whatever. But it's easy to create these myths based on race to justify differences that get the results that you want to see. And I'm not saying you all, but this is what people in this country want to see. This is how drug companies sometimes will determine who should get a certain drug and who shouldn't. All of these things are not based on fact, but they're decided by other factors. And so this was an article that came out in the New England Journal after all of these algorithms that included race. Why is it in the year 2020 people are including race in an algorithm just as much as they use other scientific factors to decide what we do or don't do in terms of working up, in terms of treating, whether they should get surgery for this or whatever. But by putting race into basic data and decisions, all this does is it propagates race-based medicine. This whole idea that we need to treat people of different races differently because they are different, although it has not been proven. And we represent white patients as the normal, but we have to race adjust for things for people of color and people of different races. And race should really only be used when you're getting descriptive statistics, when you're looking at epidemiology. It should not be used as a cause. It's just like, why are taller people better at playing volleyball, for example? It's not because they're genetically better at volleyball, it's because it's a sport that benefits from people being tall. That's all it is. So race should really only be used in descriptive statistics when you're looking at epidemiology, not in trying to determine who is more likely to get this or less likely to get that. And it also ends up creating one group that is abnormal and another group that is, quote, normal, which is totally non-scientific. The Genome Project proved that we were 99.9% the same. So there is no normal or abnormal, we're all the same. And these are just some of the algorithms. I won't go into this in detail. You've heard of these, but these nowadays, with evidence-based medicine, when I trained, there was no evidence-based medicine. We had clinical judgment. It was sort of, I think this guy is really sick, or I think this one isn't so sick. And we had clinical judgment based on data. And now we have algorithms and we come up with, well, if you score 10 points on this, you should get this treatment. If you score only 8 points, you should get that treatment. And this is how evidence-based medicine works. But it only works if your algorithm data is accurate. And when you put race into algorithms, is your data accurate anymore? What does that mean? When you put a non-scientific factor into a scientific algorithm, and this is how you decide what to do. And there's a lot of racially inequitable outcomes that come from putting race into some of these algorithms. If you look at chest surgery, for example, the data will show that Black people have worse outcomes with chest surgery. And so surgeons often don't want to operate on Black patients because then their outcomes look worse. And so what is it about being Black that makes them more likely to have a bad outcome? There's nothing about them being Black. If they have social determinants of health that you need to address to better their outcomes, then that's what you do. It has nothing to do with being Black. And so a lot of these diseases, in their algorithms, they include race. But all it does is it confuses the outcomes. It detracts from Black patients getting the care that they really need. I mean, it's been proven that Black patients don't get transplants the way they should. They don't get dialysis the way they should, all because of that algorithm. So that it's not a scientific way to practice medicine. And I encourage you, when you get into your clerkships, when you start seeing patients on the floors, when you start coming up with, this is what I think we should do for this patient, or this is how we should treat this patient. Don't let the attendings, your residents, or anyone encourage you to add race into that factor. You can add your social determinants of health. That's different. Because if someone doesn't have someone to take care of them post-op, they may have a bad outcome, whether they're white or black. We know that. So we can, like I say, the social determinants of help determine that, and it's not related to race at all. It's not related to race at all. And we have to use that. And what has happened is that using race really dilutes the effects of using objective data, because we allow the use of race to cover up the effects of poverty and the social determinants of health. Now, I want to get into how the whole idea that race has this impact in everything that happens in this country with this population. And it really determines of where you live, where you go to school, where your water comes from, that comes out of your faucet. All of that is related to how you live. And I think learning the history in this country is so crucial. And it's no different from if I complain of shortness of breath. You want to know the history of my symptom. Did I wake up this morning short of breath, or have I been getting more short of breath over the last 3 months? Your differential is totally different with those presentations. So the history of what has happened, it is important for us to know. But one of the things, this is a map of Chicago. And ever since after the Civil War ended and Reconstruction was dismantled, there has been racial segregation that has been promoted and made to be a legitimate way to determine where people should live. And the FDR's New Deal was really cemented this, despite the fact that the Homestead Act gave white people free land all over this country that blacks weren't able to get, because this started during slavery when blacks couldn't own property. And then there were more things that happened later, but to be able to get land. So what they did with the FDR's New Deal was that they determined where blacks could live. And they redlined those areas. That is, the banks that were supposed to give certified mortgages, and they were funded by the federal government and protected during the New Deal so that it allowed people to buy a home. Blacks were not able to buy that home because the banks would not allow mortgages in areas that were not approved. And so this happened. The only places that Black people could live were places that often did not have good water sources, other things, but they became segregated, and they also became poor neighborhoods. They didn't have the infrastructure like pipes and roads and schools that make a neighborhood healthy. And this is just a map of Chicago, and you can find these maps. I think the Robert Wood Johnson has this, system has this, the foundation has this. But if you look at any large city, and you look at where Black people live and you look at white people live, you will see the differences in those neighborhoods. And what happens is what this shows, this black line is one of the public transportation lines in the city. And if we leave at the bottom of this line, which is in a poor neighborhood in the south side of Chicago, go all the way up to the city limit of Chicago on the north end, which is very, very wealthy. The life expectancy increases by 30 years by going up that line. And that's related to the resources and the support of communities as you go up that line. And poor, segregated Black communities have fewer resources and all the other things that are important in having a productive neighborhood. Things like food stores, access to transportation, schools, all of these things are missing in Black neighborhoods compared to wealthier white neighborhoods. And remember that schools are based on property taxes. So if you own a home that's worth $1 million, you pay more property taxes, and that supports the neighborhood schools more. If you own a home that's only $100,000, you pay less property taxes, which means less money going to the schools. And where are the $1 million homes? In wealthier white neighborhoods. The $100,000 homes are in poorer neighborhoods. So the structure, remember I was talking about, it's the structure that creates this. And that's the structure. It's not dependent on who's going to buy your house. It's dependent on a structure that'll only allow certain people to be able to buy certain houses. This is another picture in Chicago, and what this is talking about is about air quality. And the red areas are the areas where poor Black communities are. The green areas where green is good. I mean, the air quality is better. And so what happens is that your zip code really becomes the major factor of how healthy your life can be. It's not about this. If you're living in an area that's next to a factory that's polluting the air, your children are more likely to have asthma. They're more likely, and adults are maybe more likely to get lung cancers. It'll make emphysema. All these things are impacted by the social determinants of health, what's surrounding you, and what makes your diseases worse. And in Chicago, African Americans are about 3 times as likely to die from exposure to pollution as others in other neighborhoods and aren't. Black children are more likely to have asthma. They're more likely to go to schools that have lead paint, that have mold in the walls, and other triggers. So all of this builds on, and that's why I say your zip code is so important. And remember that there's only certain places that Black people, migrants, people of color are allowed to live. A lot of it's because they can only afford certain areas and they are not welcome in other areas. I know other physicians who have bought $1 million homes who have not been welcomed in their communities, regardless of the fact that they are able to afford those homes. So it's not just being able to afford it, it's whether you are welcome in those communities and whether you can access the advantages that come in those communities. And this is because of the housing laws that have been in this country for years. And one of the things that has also occurred in this country is we have what we call concentrated poverty. And this all started back with, even before the New Deal, with bank supported mortgages. But what concentrated poverty is if you have a neighborhood where more than 30% of the inhabitants of that neighborhood live below the federal poverty line, then we call it an area of concentrated poverty. Now, remember, the federal poverty line doesn't determine who's poor and who isn't. It just determines who can get access to certain benefits. Because people over the federal poverty line, many are poor still. But it's just a line that gets drawn as to who can get access to certain benefits. But if you look at this, you'll notice that there's many more Blacks who are living in higher percentage that are living in concentrated poverty than whites. And that is because poor whites are still accepted in wealthier white communities than poor Blacks are. And so poor Blacks do not have choices that poor white people have. And with a poorer community comes poorer schools, poor resources. There's often not a grocery store, and we wonder why poor patients eat so much fast food. It's because there is no other source of food often in those communities. There's often not even a bank in these communities. There's a payday loan or something, and that was a really crucial problem when COVID came out and small businesses applied for loans, but many small businesses in Black communities didn't have a relationship with a bank and couldn't get those loans. So it feeds into everything. It's like a web. It's the fingers get involved in everything. So that if you look at all of these other cities where poor white people have access to better living areas, and that's why poor white students often have access to better schools, all the other things that allow children to grow and prosper are available to poor whites than they are to Blacks. And this is just to show how these policies and where Blacks are able to live, where they are able to work, that the amount of money that Blacks have in terms of wealth. And when we talk about wealth, we're talking about how much money you have saved, not your income. And your wealth, your savings, wealth is more important than your income. There's a lot of people who have high incomes who have, a lot of credit due. They put a lot on credit cards, they buy a house too low, whatever. But it's more important that you have wealth, because this is where your kids will start. If you have money to leave for your kids, they won't have to start at square one. But when you have no wealth, even if you're not in debt, you leave your kids nothing, and each generation will continue starting at square one. And that's part of the problem, the way this finance system has been set up, is that it becomes much more difficult for Black families to accrue wealth than for white families. And so if you have, and also we have a healthcare system in this country that is based on one's ability to pay. And studies have shown that families that get an unexpected $400 bill often cannot pay that. It's a large percentage that cannot pay that 400. So when you talk about healthcare as an unexpected expense, it can destroy a poor family's finances because they cannot afford to pay that. So, and also having wealth allows you to access loans. Like I say, it helps provide your children with access as they get older. So it's not fair, because we Black people were not allowed to share in all the benefits that white people in this country had to accrue wealth and to access assets. Black people don't have that. And so it's never equal. It's never equal with this system. So this is just a graph that talks about in poor neighborhoods. This graph is hard to read, I know. And I tried to find another one that said a little better, but it just talked about pharmacies. When we talk about what is missing in poor communities, one of which is pharmacy. And in Chicago has about 800 census tracts, and a third of those had no pharmacies. So they are what we call pharmacy deserts, and we call a pharmacy desert when you live more than a mile from a pharmacy. And a pharmacist, sometimes we forget how important they are in people who come to pick up pharmacies. And I know a lot of times medicines get mailed to patients, and so there's no one to talk to. And you wonder, I started this medicine yesterday and now I have headaches. Is this from this medicine? They used to be able to go to a pharmacy and ask the pharmacist. Now they can't do that. And it's even more difficult to get a doctor on the phone or somebody to answer a question for you. But if you look at neighborhoods that are well integrated or segregated white neighborhoods, they have many, many more pharmacies than if you look at Black segregated or Hispanic segregated communities. So that even though you may see a doctor who may get you a prescription and a prescription for your medicine, you may not have access to a pharmacy so that you actually end up with those pills in your house, or that you have access to ask someone about that. And also pharmacies are at higher risk of closure now. And it's those with a large customer base on public insurance. Those pharmacies often get closed. They get closed because they can't, if they're on Medicaid, most of their Medicaid patients, they don't make enough money to maintain. And you don't find large chain stores like CVS or Target with pharmacies in poorer communities. So there's often not a way for poor patients to access a community. And if we look at the hospitals that are in poor neighborhoods, and this really became clear with COVID. And I remember seeing on the news early in the COVID pandemic, and the chairperson of the AMA, the American Medical Association, and she was asked, why is it that poor communities are having more deaths and suffering more from a higher incidence of COVID? And her answer to that was, well, we'll have to do some more studies. But the problem was that in these poor neighborhoods, there was no way for them to access care. There was no way for them to access testing. There was no way for them to socially isolate. Their homes were more crowded. Even though the density of the neighborhood may be less because there may be a lot of vacant lots, each unit of housing was often crowded. So you had maybe 10 people living in a 3-bedroom home or a 2-bedroom home, so that there's no way to isolate yourself. And plus, people in poor communities have jobs that they come in contact with more people. They live in a job that requires contact. They don't have a luxury of working from home on Zoom. And so if you look at where these patients often need to get care for COVID was in an ICU, there often wasn't one. In a community, if you look at a community whose income was less than $35,000, half of those communities did not have an ICU bed, not a single ICU bed. And communities that were wealthier, that had over $90,000, almost all of them had ICU beds. And one of the things, when an ambulance takes a patient to a hospital and a hospital doesn't have a bed, that patient now has to get transferred because they've been taken to that hospital already. And wealthier hospitals can choose not to take a transfer. By law, though, if you present to a hospital with a complaint, you have to be seen. If you want to see them because you have a hangnail, that's up to you if you want to pay for it. But they legally have to take you. But they don't have to accept a transfer, even when you have beds available. So poor people often were not able to access the hospitals that could treat them appropriately because they didn't have the facilities for that. This is interesting. You know, I read this article and I put this in here, but about autopsies, and I never thought about biases in autopsies before. I thought, you know, you look at the heart and lungs, all the big organs, and if there's a mass, you do a biopsy and you figure out if this is malignant or whatever. But this was a story that was written in the New York Times, and it was about a woman who had a young infant who had a bad cold and was getting worse. It was getting more and more in respiratory distress. So she decided, I need to take him to the emergency room that evening. She took him to the emergency room. I think this was in New York. Took him to the emergency room. The baby arrested while in the emergency room. The ER staff tried to resuscitate him. Apparently, they worked on him for a long time, over half an hour, but the child unfortunately did not survive. So because it was a death in the ER, there was an autopsy done. The pathologist described the cause of death as child abuse, based on the fact that there were cracked ribs, which were because of the chest compressions. There were multiple bruises and things because of attempts to get access, venous access. This poor woman went to jail for over a year before an attorney finally took her case. And the reason that the pathologist never looked at the chart, but this was a poor Black single mother. It had to be child abuse. And so even though I never really, I know that there is bias within and how they look at things, but this was just outrageous. And part of it, they think too, is because pathologists often have relationships with the police, because they see a lot of patients that may be brought into that are already deceased or with massive injuries that may have been done by the police or whatever. But this is something that is just inexcusable, that a pathologist would make a diagnosis of that without looking at the medical record. And this is just a chart on how we fund disease. And this is a comparison of how we fund the differences between sickle cell disease, which is not just Black people. I have seen a couple of white people in my career who had sickle cell who grew up in sub-Saharan Africa. And the difference between sickle cell and cystic fibrosis, and if you look at how much more prominent how much more often children are affected with sickle cell. Sickle cell affects one in 365 Black children. Cystic fibrosis affects 1 in 2,500 children. So sickle cell is much more prominent in this country than cystic fibrosis. But look at the funding. Despite that, the government doesn't fund it well. It's not equitable at all. Neither is foundation funding. I mean, when you look at this, I ask you, is this race or racism? You can answer that. Why is there no money going to sickle cell? And even though there's a lot more research articles on cystic fibrosis, there's more research done for cystic fibrosis than there is on sickle cell. And there's not as many new drugs that come out. And this is a book, I don't know if you've heard about this, Medical Apartheid. It's a phenomenal book by Harriet Washington that talks about the history of the abuse by the medical healthcare system on doing studies and inappropriate treatment of Black patients. And it's just, we all know about the Tuskegee Institute, but there is so much more. I don't know if any of you are going into OB, for example, but there was a gynecologist, Sims, who did a lot of studies on how to fix the cystic vaginal fistulas that come from childbirth that takes too long and the head sits and it causes necrosis of that wall. And so now there's a post-op fistula. And it doesn't happen anymore now because we do cesareans and all that. But what he did was he did a lot of studies and procedures on Black slaves who had this and trying to find a way to fix this. However, he did all these surgeries without any anesthesia in trying to find how to fix this. And to this day, this physician is often not the chair, but his name is a chair for their OB-GYN departments. And they justify that by saying, well, he found a way to fix this problem, but the way he found it was totally, totally wrong. You don't abuse slave women without anesthesia to try to do this. And so there's tons of stories about this on how apartheid, this medical apartheid has continued. And even to this day with the CTE, we're still treating Black patients inappropriately, and one of the things that, people talk about, to me, it's that we have to get Black people to trust the healthcare community more. We have to encourage them to find healthcare. But would you tell an abused woman to be nicer to her husband so he doesn't hit her? He's not hitting her because he's not nice. He's hitting her because that's who he is. It's not the solution of the victim that's needed. It's a solution of the perpetrator. And unless healthcare changes the way we address disease and the treatment of minorities, there will continue to be stories like this. Even with the COVID vaccine, there was an article I read, and this was early in the pandemic, and they were talking about we need to test the vaccine on children in Africa. I don't know what country in Africa they were talking about, but the whole idea that they would do this now, test it on Black children, tells you we have not come very far from the Tuskegee Institute. And this is just the establishment of Medicare and Medicaid in 65, which created the desegregation of hospitals. And this was actually, a lot of this was initiated by a Black dentist who had a patient who had a huge tooth abscess who needed surgery, and a white hospital would not take him. And I can't remember if he died or he ended up going somewhere else, but this sort of spurred the whole thing, you know, was one of the things that got us to desegregate hospitals. Really, what Johnson did, LBJ, doing this, establishing Medicare and Medicaid. And what he said with the Civil Rights Act too, is that if you don't desegregate your hospitals, you will not get any federal money. You will not get federal money through Medicare, and you will not get federal money through Medicare or Medicaid. And this is a picture of him signing this. And there were two Black men at that signing. One was Martin Luther King. The other was Dr. Montague Hobb, who was the president of the NMA, which was the Black Medical Association, because Blacks were not allowed to be part of the AMA, the American Medical Association. They were not allowed to be part of the AMA. Therefore, they could not get into residency programs. They could not get on hospital staffs. They were isolated in their own community hospitals. And there was not a single physician from the AMA at this signing, and the AMA did not support this. And we still have issues. I mean, I look back at myself. I won't tell you when I was born, but I was born at a Black hospital, because in Chicago, even if you went to a white hospital, you were put away in some wing off to the side to deliver your babies. You may have been in the same room as somebody who just had, you know, an appendectomy or whatever, you know. And so my brother and I, we were delivered by a Black physician in a Black hospital in Chicago. So I want you to read this. I'm not going to read it outside, but I mean, read it out loud. And I think, as you know, I can look back at my career and some of the comments that were made to me, that those will still be repeated and said to you, unfortunately. You know, that you don't need to be here, that you should not have been accepted, or whatever, you know, but stand your ground. And I think that there are more and more physicians who have your back. I have your back. Reach out to me. But I think that as students, you need to say something when you see these discrepancies and this behavior that is totally inappropriate. And it happens. I mean, look at who gets into medical school. And if you look at the wealth of physicians and whatever, but I'm not criticizing people who are wealthy, but oftentimes it prevents you from seeing what others have to go through in order to get to have. So the thing is, remember that the structure survives. All of that iceberg that's underwater will always be there. Maybe global warming will destroy it. I don't know, but that iceberg of health inequities is there. And it will continue. It's not dependent on individuals for it continue. But what is dependent on individuals is to destroy the structure. And that's where we fit in, and that's where students come in. So I leave you with this thought. There are a lot of brilliant physicians who don't teach you the morals of how patients should be treated. And this is just some a website with the Physicians for National Health Program and a lot of other websites that give you a lot of information. I know you're getting talks on single payer and all of that during your internship and all, but I have time for questions. I know I've used up most of my time. I talk too much, I apologize, but so any questions?
I can start. Dr. Rogers, I thank you so much for coming and speaking with us today, as well as last time when you came and spoke. I really appreciate your insight and just your passion for taking care of folks. The question I had was just, you kind of detailed to us also last time when we spoke, what kind of encouraged you to get into medicine and I know your work with PNHP over the years has been an outlet for you to serve as an advocate for your patients. I was just wondering if you could share maybe a little bit more about that, your personal experience through medical school, residency, and then your time as an attending. I know each one of those seasons has obstacles in and of itself just to survive each of them and hit all the objectives and the tasks placed in front of you. So I was just wondering, what were some of the ways you were able to continue to advocate throughout all those seasons, and just maybe like the most fruitful platforms or spaces you were able to advocate during all those seasons, if that makes sense.
Yeah, no, yeah. I had an interesting journey to going to medical school. I didn't go to college knowing that I would go into medicine. I didn't know what I was going to do. I just wanted to be a biology major. And then when I finally decided to do that, I said, and this was during the, the civil rights movement and all, this was, in the 70s and all. And I decided I wanted to go to Cook County to be a Black physician for Black people. That was my choice. I wasn't into, it's not that I wanted to make a lot of money. I knew I would make money as a physician. I didn't have to worry about debt because that wasn't as much of a problem back then as it is now. But I think I had the passion, and that was my mission. And then I got more involved with teaching when I was there at Cook County and on the faculty at Rush. I got more involved with teaching. And I think that we all have to kind of follow and do what we like doing. Because, I'm one of these, I could have never been a surgeon or even going to OB, because I learned doing my OB as a student that when things go wrong, they go really wrong. And I don't like that, although most of the time they got it fixed. But that wasn't my personality. So find how your personality functions. If you like talking to patients, maybe primary care is the way to go. And that's what I was in primary care. And find out what you like, because I can tell you, no matter how much money you make, it won't make you happy. It'll make you rich, but you'll be rich and unhappy. Because it's that passion, it's that doing what you like. to me, there was nothing better with, when patients come back and thank you and they, tell their family about you and they appreciate what you've done for them, especially minority patients, because they often don't find that in other parts of their life. So be honest with yourself about what you like doing. If you like cutting and you like, surgery type stuff, then do it. It'll make you happy, you know? If you like children, maybe peds, but be honest with yourself about what you like. And a lot of this may not even show up until you start doing clerkships. And then you really see what it's like to be whatever. Okay. And spend some, in your fourth year, spend some time doing some things that you hadn't really thought about before to see if you like that. But that's the key, but do what makes you happy, because I know a lot of, it'll make life easier if you do what you like.
Absolutely. Absolutely. That makes sense. Thank
Yeah.
you. And
You're
I also just was wondering, with that in mind, but more so outside of the clinical space, in terms of like advocating for your patients on a systemic level, as you do with PNHP and organizations like that. I was wondering how you were able to maintain that, or what that looked like during different seasons. I'm sure it did, like through residency and then becoming an attending, if that makes sense.
I think I always had this sense of activism, but then I got married and had children, and that took all my time. But it's, your time availability will vary with what's going on with your life. And you have to respect that. When you're an intern, you may not have time for activism. And that's okay, because if it's in your blood, if that's part of your mission in life, you'll get back to it. And it's okay to step back from it for a while when other things have a higher priority in your life. So don't think that you have to do everything that you're doing all the time forever. It'll change. And you'll have to accommodate other aspects in your life. But
Gotcha.
you'll figure it out. And one
That
of
makes
the
sense.
things too is it never hurts to get a mentor. If there's faculty in the hospital or in the school to help you kind of dissect through some of the choices you'll have to make, such as, where do I want to train? What do I want to go into? Do I want a university setting or a smaller hospital? And that depends upon what you want to do with your life as a physician.
Thank you.
You're welcome.
I think I can ask the next question. So first of all, thank you so much for your presentation. I think one of the things I appreciated is that I don't know if everybody has the same experience, but like as medical student, we have now like, at least in our school, we have like another course which is called HNP, where we literally like get to learn how to deal with patients from various backgrounds, be it like difference in races or like gender identification and stuff. But I feel like after your presentation, I think, at least that's my personal experience, that I tend to lose sight on not to see things differently, at least in medical sense, because like based off of those trainings, we are like, okay, we have to take special consideration into account while dealing with patients who are from different backgrounds. But I think now that I reflect back on it, I don't think that's at least necessary for medical purposes. So my question is like, how to make sure that, we are not taking that medical racism. I think that's what you referred to in your presentation, while dealing with people from different backgrounds, but also at the same point, try to be considerate.
Yeah, you have to kind of look at you know, the patient, and it's hard, if you're working in the hospital, you often don't know your patients that well because you've seen them for the first time when they're sick. And depending upon how sick they are, you know, and you may interact with the family more, you know, if you're seeing patients as outpatients, you know, and you get to know your patients better individually because you see them in a more relaxed setting, they're not acutely ill, and you get to get an idea of how you get to know them. I mean, I worked as a PCP for many years and then also as a hospitalist for many years. And the way I see the two differences, as a PCP, I took care of people. As a hospitalist, I took care of problems. And so a lot of it depends upon how you like to function, you know, and sometimes you just have to spend extra time talking to patients and see. I mean, some women will only do what their husbands suggest, for example. Some people will leave all their decisions to their adult children, for example. I mean, there's a lot of that, and you kind of have to weed through it and figure it out. But each patient is an individual. So there's no recipe that works for all of them, you know, and it takes time. You have to spend time doing, and then there's culture differences, you know, in some cultures, this is the way it's always done. And you have to respect that, even if that's something that you would never do personally. So it's hard sometimes. It's hard sometimes, especially when acute decisions have to be made. Like if you go into the ER or something and somebody is very ill or somebody arrests, and I mean, it can be difficult, but.
Makes sense. Thank you.
There's more hand.
Yeah.
Okay. I can't read it on this thing. Hamza?
Yeah, it's Hamza.
Go ahead.
Thank you very much. My question was actually sort of related to your work as the president for PNHP. So one of the things you mentioned was the Tuskegee Institute. And so, you know, that is one story where there's a large distrust of the government and sort of like larger institutions. My question is that, you know, as physicians and advocates, do we have to sort of make progress on that front prior to advocating for something big like single payer? Or is it that single payer can be used as sort of a positive direction to remedy some of those issues?
Well, to address that, it takes a whole global thing. It's not, I mean, as individuals, we can say certain things, we can emphasize doing or not doing certain things. But to change things, it's going to take the organization. Now, PNHP is focused more on the ability to get healthcare paid for everybody. And that would be a single payer system. That's what we advocate for. It doesn't serve as a filter for, I'm trying to find a nice word. I'll just say assholes because you all know what that means, but it doesn't filter them coming into the healthcare system without the right moral structure or infrastructure. It doesn't prevent that from happening. And a lot of that, you know, comes from interacting and discussions with patients. I mean, not just with other physicians. And you'll see that there's certain specialties that tend to have a certain personality. I think you know what I'm talking about, but you know, they are, and there's some that are very homogeneous, and those are difficult to get into and to change the culture within that. That is difficult. And I mean, it's like anything else, you know, it's like you would think that teachers in primary grades would love children. Well, they don't all love children. We know that, you know, whether they should, I think they should at least care enough about them to do the right thing. And it's the same thing with doctors. We would think that they would want to do the right thing, even if it's somebody that as a person you would never want to see again. You still want to do the right thing for them. And we just have to, you have, as an individual, you have to do that. And one of the things that don't forget is that you never know who's watching you. So if you're always doing the right thing, you'd be surprised at who sees you. And I've had people come back, students have come back to me later and said, Dr. Ryan, I remember when you said such and such, and I remember that. And people remember what you do and what you say and how you react to patients when you do it in a way that they appreciate or that they see as the right thing. So you never know how well it's going to work, but it will. It's just like in your own life. You never know who's watching you. Macaulay?
Hi, first of all, thank you so much for coming and talking to us. I was very excited when I saw your name on our list again. I wanted to ask, I'm sure over your career you've seen a lot of changes in medicine. I was wondering what you see in medicine right now that makes you feel hopeful for the future and what changes you see on the horizon for medicine.
You know, depending upon the presidential election, I don't know what I'm going to be hopeful about. That's a
tough question right now.
Yeah, it is. But I will say that I think one of the things I'm worried about is that students lose their goal to be the doctor they started out wanting to be. And, you know, we all see things that we see are wrong or whatever. And it's a stressful time and you question your judgment. Am I wrong thinking this or that? And I think it's important to communicate, to get involved with organizations that in different ways put patients first, like PNHP, which advocates, you know, for the finances of healthcare so that patients aren't financially destroyed because they got sick, you know, and that, you know, when you see patients who are, you know, not appropriate with patients, I think you need to, and one of the things that helps with speaking out about things like that is to have a relationship with an attending who has your back. You know, because if you get called out on something that isn't necessarily wrong, but you don't want it to cause trouble for you, you know, to have some sort of relationship with an attending physician. And you may have different relationships with different attendings. There may be one who is going to give you guidance in terms of what, where how to make your match list. You may have one that's helping you deal with life issues while you're a student. You may have, you know, it all depends, you know, but it's just like your friends, you know, you have different friends there may be some friends you go to movies with, there may be some friends you go running with or whatever, but you know, you have to have your backup. And I would say, try to have that support system with you that you can use as a resource and develop those relationships. And you'd be surprised that physicians like that. I liked it when students would keep coming back and asking me stuff, you know? After my teenagers didn't want to ask me anything, it was nice. You know, people younger ask me stuff, but you know, you need that. So you'll have a variety of sources.
Thank you.
So anybody want to go into internal medicine or become a PCP, or do you all have any idea what you want to do? It's still early. What do you want to do? Hamza?
like family practice. I think a lot of folks here would say the same.
Good, good. That's a good one.
I wanted to do neurology.
Okay.
I think OB-GYN.
OB-GYN, okay. That's a scary one nowadays because you don't know what you can and cannot do. It's just horrendous.
I'm in
But-
Texas. It's a hard out here.
Yeah.
For me, either family med or urology. But we have rotations in 6 months, so I'll find out soon enough.
Yeah, family med or urology, those are miles apart, but good.
I like pathology, so that story you told us kind of made me mad.
Yes, it should make us all mad. It's just horrendous, yeah. Yeah,
Yeah, I'm thinking internal med, probably cardiology or general, not sure yet, but
okay. Okay. I liked internal medicine because I saw a lot about a lot of different things. And and as a hospitalist, you end up getting consults. So you really learn a lot about a whole lot of different stuff. It's not just hypertension and diabetes, and to do that. So I find it always challenging and always interesting, and it's always fun to figure out something that someone else couldn't figure out, and and teaching I really liked because it keeps you on top of stuff. So you made
I'm
me
interested in family med as well.
family med, okay. Yeah, most in family med. I'm not sure how it is in terms of getting OB-GYN privileges in some hospitals as a family medicine. I know that it was getting more difficult and to get insurance to cover if you still want to do deliveries. But that's a good one. Okay. Well, I enjoyed this. And I hope that you all learned a lot. And I think that I've sent my slides that I think have the notes on there. So that's got some of the things that I had put in there that discuss what I said. Because a lot of times seeing the slide, you forget, what did she say about that though? And so that's in there. So, and feel free to reach out to me if you like. And I am in Chicago. So if you're ever up this way, let me know.
right,
Okay.
thank you so much for
Okay.
everything.
Thank you.
Good luck and enjoy the rest of the internship. Okay.